Hello everybody, it's Dr. T here. Wednesday night we have just finished up here at Womb with our amazing mood food talk with Nick Nation, our dietitian. And I promised you I would do a rapid fire Q&A. Shani Marie, what are you doing up so late? Lovely to see everybody who is on. Say hi, let me know where you're coming from. I am still here at Womb. We have just finished an amazing talk with Nick Nation, our dietitian. Oh my God, my brain is spewing out of my ears. There was so much to learn. And what is amazing is that he's going to do it as an online event. So we are going to be able to show it to you right here on Insta, hopefully, in the next couple of months. So I promised everyone a rapid fire Q&A. So I'm going to time this. We are going to take 10 minutes. 10 minutes. So this is your opportunity. I'm going to keep it short and sweet. So no personalized questions, just one question. Go. Anyone got a question to ask? Let's get it happening. I can't see any. There's lots of people online. Lots of people waiting. Come on, you must have questions. The time is ticking. Make it short, make it sweet. I would love to answer it. You know, tonight we talked about a lot of stuff to do with the gut-brain axis and how much food. Oh, here are some questions. What are the signs of endo? Well, they can be nothing. They can be pain. They can be fatigue. They can be weight loss. They can be infertility. Endo presents in so many different ways. That's why it's such a difficult disease to manage. What are your thoughts on folic acid in the second and third trimester? Folic acid is important for DNA synthesis. You are growing a human being. So although all of the research around neural tube defects has been done around conception, folic acid is important to continue to take throughout your pregnancy, or at least get it in your diet. How does progesterone help support the luteal phase? Well, the predominant hormone that is nourishing the endometrium is progesterone, and the window of implantation is day 4 to day 10 after you ovulate. So that is the luteal phase. So you need progesterone to create a receptive endometrium for your embryo to implant itself. Thin lining, how do you increase it? With great difficulty. There are lots of strategies, none of which have been conclusively proven to work, but it really depends on why you've got a thin lining. It could be poor blood supply. It could be because you've got scar tissue there. It could be that congenitally your endometrium doesn't grow very well. So we use a lot of different techniques, things to vasodilate, things to act as antioxidants, and sometimes even surgery to treat Asherman's disease. Progesterone intramuscular injections are a common form of treatment. No, it is not common. Is it effective? Yes, it's highly effective, but it is a treatment burden. To inject yourself into your muscle every day is a painful experience, has been associated with abscess formation and certainly painful lumps. And if you are pregnant, you have to continue taking it right through until the second trimester. So it is not commonly used. It is highly effective. And yes, I do use it for those who I don't think metabolize progesterone particularly well in other ways. Did I miss any other questions? Come on, there've got to be more. What have I got? I've still got 6 minutes. Let's have some more questions coming through. What else? Test my brain. Anyone else have any questions? Justine's on. Ali B's on. Janet's on. The Wandering Mum, I love that name. IVF been here. Clever. What tests are completed following recurrent pregnancy loss, multiple miscarriages? Well, the most common cause is a chromosomal abnormality in the pregnancy. So we look for heritable chromosome copy number issues, so translocations in the parents. We look for anatomical problems, so in the uterus, in the lining, polyps, fibroids. We look for endocrine problems, prolactin, thyroid, sugar issues. We look for heritable thrombophilias, so clotting disorders. We can look for some autoimmune conditions, but then we're starting to get into the quite vague things. But the reality is in 50% of cases, we find nothing. Okay, another question. Do the chances of a successful conception decrease with each unsuccessful cycle with tracked hormones? There have been some studies that look at conception over time, and we do know that as a woman ages, obviously, but also with progressive number of menstrual cycles beyond the time of which active conception is being undertaken. So this is spontaneous conception that you're talking about. Your chances of conception do decrease. So for example, if you're looking at 12 months versus 18 months of trying, at 18 months, your predicted pregnancy rate is going to be less in the ensuing months than if we'd looked at you at 12 months and you were looking in the ensuing months after 12 months. So yes, they do decrease because something's going on. All right, another question. These are great questions, guys. Did I miss any? Can you do IUI unmedicated with frozen sperm, and when do you know? Okay, all right. Can you do IUI unmedicated? Yes, doesn't increase your pregnancy rates. With frozen sperm, highly not suggested. That's not very good grammar. Sperm don't like being frozen. So you'd have to do a test thaw and make sure that the motility after freezing is okay. But generally speaking, I wouldn't encourage it because sperm motility is much poorer once it has been frozen. So it's not gonna swim where it needs to go. So I wouldn't bother, Janet. I would probably do superovulation and IUI if I was going to do anything. What's your management of clients post-IVF and people who continue to experience amenorrhea? What's the long-term effects? Oh, okay. I guess it depends on what the cause is, but if we're talking about something that's functional, for example, like a functional amenorrhea, which is probably driven by the hypothalamus shutting down, you've got to look at the strategies around weight management, around stress management. Are there any congenital anomalies which have to be managed? And if I can't find anything, well, I'll often talk to them about HRT because I worry about their bones in the long term. 6 months without any estrogen in your system and you will start to significantly reduce your bone mineral density. So HRT. What's the main difference between IUI and IVF? Oh my God, where do I start? IUI, we just simply put the sperm inside the womb. So we wash it up, we put it inside the womb, and it still has to swim to the tubes, and conception, so fertilization, still has to happen. IVF, we take the egg out of the body. In fact, we take multiple out in most cases, and we can perform ICSI, where we inject a sperm into the egg, or we surround each egg by about 100,000 sperms, so they don't have to swim very far, and then the best one wins. So really, IVF is like a souped up version of every stage of that conception journey, and that's why the pregnancy rates with IVF are so much higher than they are with IUI. Apart from the fact it's the first time we actually get to see the eggs and the sperm interact with each other, which you never get to see in IUI, so you don't even know if fertilization's happening. Weird question, trying not to make it too personal, thank you. But with all the progesterone support, would the body rid a pregnancy if there was an issue with the fetus? Oh, that is a really great question. Look, sometimes we actually think to ourselves, we need to stop progesterone support to allow the body to miscarry. So there is a thought with pregnancies that are borderline, that would not normally have continued due to fetal issues, that if we were to continue supporting it, would just not allow it to miscarry in the appropriate amount of time. So we'd be looking for other features that are suggestive of an inevitable miscarriage to stop progesterone. Oh, these are such great questions. What have I got? I have 2 more minutes. Has anyone kept count of how many questions I've actually answered? This has been insane. I've loved it. Gosh, my adrenaline is absolutely rushing. Nick would be killing me right now talking about mood and food. Apparently, I've got to be more zen and mindful in my eating. So I've got to learn to chew my food. Firstly, I've actually got to sit down and eat my food. And then I've actually got to chew my food and enjoy it and put my fork down between each bite. So that's the crux of mindful eating. Let's see if I can do that tomorrow. Any more questions? I'm about to finish this off. Any more questions? I have 1 more minute. Come on, guys. I'm sure we can fit 2 or 3 in the last minute of time that we've got. 11 questions. Oh my God, you were actually, that's fantastic. You were actually counting. Brilliant. You can come back. Time from IUD removal and trying for pregnancy. Well, it depends what sort of IUD. If it's a progesterone infused IUD, then you probably need to actually grow a lining in order for a receptive endometrium. And so you would need to have an ovulatory cycle. Now, when you've got an IUD in place, you're still having ovulatory cycles underneath. So yes, you could conceive as soon as an IUD has come out if you have just ovulated. But ideally I say to clients, it would be nice for you to have a period first, so that you can grow a really nice rich lining for that little embryo to implant into. Sarah Lawther, how are you? All right, what should be a normal bleed using progesterone? When should we go back to the specialist? A normal bleed using, well, really a normal bleed. Normal bleed. What is normal? I would say that a bleed should happen for no more than 7 days. Particularly if you're using progesterone support, I really think it should be less. But if it's troubling you, just go back and see your specialist. Do you need to have cysts for PCOS? No, you don't. Your ultrasound can be completely normal. But if you have very irregular cycles, so you're missing the occasional one, and you have evidence on your blood test or clinically, so of hair growth or acne, of high levels of male hormone, that's enough to classify you as PCOS. I think I'm done. I hope you guys are done. I hope you got something out of this tonight. Thank you so much for joining me. I know it was short and sweet, but we had an absolute blast here tonight learning about mood and food. Keep abreast. We have more seminars coming and workshops. I know lots of people not in Perth have asked if we would do some stuff online. Don't you worry. It's coming. I haven't forgotten about you guys. Thank you so much. Okay, living on a pair. Is it worth seeing our specialist if our AMH has gotten worse with diagnosed PCOS? I think don't panic too much about the AMH. It's not a measure of fertility. You just need to try and get pregnant. And that's your judgment about whether or not you're going to get pregnant or not. Wonderful, guys. Have an awesome week. Lovely to see you.